By the time you reach the end of this video, roughly 18 seniors will have just received a heartbreaking dementia diagnosis. That's one person every 70 seconds in this country alone. But what if I told you something that might shock you to your core? What if the real culprit isn't genetics, isn't aging, isn't even lifestyle? What if it's hiding in plain sight right there in your bathroom cabinet? You trust these medications, your doctor prescribed them, they're FDA approved. They seem perfectly safe, but what I'm about to reveal will make you question everything you thought you knew about the pills you take every single day. Here's the disturbing truth that many seniors are completely unaware of. Certain medications sitting in your medicine cabinet right now have been linked in research studies to changes in brain function. Some of these effects can develop over time with regular use. Let me be clear about what the science actually shows. I know this sounds concerning. I'm Dr. Robert Harrison, and I've spent decades in medicine helping patients navigate these exact situations. What I'm going to share with you today is based on published research from some of the most respected medical journals in the world. Recent studies have revealed connections between certain commonly prescribed medications and increased dementia risk, connections that most patients are never told about when they receive their prescriptions. Here's what you need to know. Several medication categories have been scientifically linked to cognitive decline in older adults. Some interfere with critical brain chemicals, others deplete essential nutrients, and a few have been shown to increase dementia risk by more than 50% with long-term use. That's not me exaggerating. That's what the peer-reviewed research shows. But here's the important part. Understanding these risks doesn't mean panicking or immediately stopping your medications. It means having informed conversations with your doctor and making educated decisions about your health. Today, I'm walking you through 9 medication categories that research has connected to dementia risk, starting from the often overlooked to the most concerning. Number 3 on this list is prescribed to millions for what seems like a minor condition, yet studies suggest it may affect brain function in ways many people don't realize. Before we begin, I'd appreciate if you'd share in the comments what medications are you currently taking, and have you noticed any changes in your memory or mental clarity? Your experience could help someone else recognize an important pattern. We read every comment and genuinely want to hear from you. Now let's start with number 9. Despite its position on this list, this is one of the most commonly used medications in America, and most people have no idea it could affect their brain. Number 9 is diphenhydramine, commonly sold as Benadryl and in countless sleep aids. That pink pill you reach for when you can't sleep, the allergy medication that's been around for decades. Diphenhydramine is available without a prescription at every pharmacy in America. Most people assume that over-the-counter means completely safe. But when it comes to brain health, especially as we age, the research tells a more complex story. Diphenhydramine belongs to a class of drugs called anticholinergics. These medications work by blocking acetylcholine, a neurotransmitter that's essential for learning, memory, and mental processing. Think of acetylcholine as the communication system your brain cells use to send messages to each other. Here's what makes this concerning. As we age, our brains naturally produce less acetylcholine. When you add a medication that blocks whatever acetylcholine remains, you're creating conditions that can interfere with memory formation. A landmark 2015 study published in JAMA Internal Medicine by Dr. Shelley Gray and colleagues followed 3,434 adults aged 65 and older for more than 7 years. The findings were significant. People who took anticholinergic medications equivalent to 3 years or more of daily use had a 54% higher risk of developing dementia compared to those who didn't use these drugs. This wasn't a small preliminary study. This was published in one of the most respected medical journals in the world. A follow-up 2019 study in the same journal examined nearly 60,000 people and confirmed these findings. Regular anticholinergic use was associated with increased dementia risk, and the effect appeared to be dose-dependent. If you occasionally take Benadryl for seasonal allergies or an itchy rash, you don't need to worry. The concern is with regular long-term use, especially daily or near-daily use over months or years. For allergies, consider second-generation antihistamines like loratadine, which is Claritin, or cetirizine, which is Zyrtec. These newer medications don't cross into the brain as easily and have better safety profiles for older adults. For sleep problems, talk with your doctor about melatonin, cognitive behavioral therapy for insomnia, or addressing the root causes of your sleep issues through better sleep hygiene. Never stop any medication suddenly. Have a conversation with your healthcare provider about your options. Check your medicine cabinet tonight and read the labels. Any product marked PM, nighttime, or sleep aid likely contains diphenhydramine. Knowledge is power when it comes to protecting your brain health. Number 8 on our list is proton pump inhibitors, specifically medications like omeprazole and esomeprazole, heartburn and acid reflux medications, PPIs like Prilosec, Nexium, and their generic versions are among the most commonly used drugs in America. They're often prescribed for GERD, stomach ulcers, and chronic acid reflux. Many people take these medications for years because stopping causes uncomfortable rebound acid production. But long-term PPI use raises several concerns worth understanding. PPIs work by reducing stomach acid production. While this relieves heartburn, stomach acid plays an important role in absorbing certain nutrients, particularly vitamin B12, magnesium, and calcium. All three are crucial for brain and nerve function. Vitamin B12 deficiency can cause symptoms that look remarkably similar to dementia: memory problems, confusion, difficulty concentrating, and mood changes. This is where the evidence gets more complicated. Some studies have found associations between long-term PPI use and increased dementia risk, while others have found no connection when properly controlling for confounding factors. A 2023 study published in Neurology found that cumulative PPI use over 4.4 years was associated with increased dementia risk. However, another 2023 study analyzing data from a large randomized trial found no association after properly accounting for other factors. The connection between PPIs and dementia remains uncertain and is still being researched. What we do know for certain is that long-term PPI use can interfere with nutrient absorption, B12 deficiency can cause cognitive symptoms, and many people stay on PPIs longer than necessary. If you've been taking a PPI for months or years, it's worth having a conversation with your doctor about whether you still need the medication, trying a gradual tapering strategy, switching to an H2 blocker like famotidine, which is Pepcid, which may have less impact on nutrient absorption, and monitoring your B12 levels and considering supplementation if needed. Lifestyle modifications can also be powerful. Elevate the head of your bed 6 to 8 inches, avoid eating within 3 hours of bedtime, identify and reduce trigger foods, and maintain a healthy weight. The goal isn't to create alarm, it's to ensure you're taking these medications intentionally, not just because you started them years ago and never reassessed. Moving to number 7, we have bladder control medications, specifically oxybutynin and tolterodine. Overactive bladder and urinary incontinence are frustrating conditions that affect millions of older adults. When a doctor offers medication that can provide relief, it's understandable why people accept it without much hesitation. Medications like oxybutynin, sold as Ditropan, and tolterodine, sold as Detrol, are commonly prescribed for these conditions. But like diphenhydramine, these drugs work by blocking acetylcholine, and they don't just affect the bladder. The same 2019 JAMA internal medicine study that examined diphenhydramine also looked at anticholinergic bladder medications. The findings were similar. Regular use of strong anticholinergic drugs for bladder control was associated with significantly increased dementia risk. What makes oxybutynin particularly concerning is that it crosses into the brain relatively easily compared to some other medications, potentially affecting memory and cognitive function more directly. Many people taking these medications notice mental fog, increased forgetfulness, or difficulty concentrating but don't connect it to their bladder medication. They assume it's just normal aging. The good news is that newer bladder control medications work differently. Mirabegron, which is sold as Myrbetriq, doesn't block acetylcholine at all. It works through a completely different mechanism and appears to have fewer cognitive effects. Non-medication approaches can also be remarkably effective. Pelvic floor physical therapy, bladder training techniques, reducing caffeine and alcohol, timed voiding schedules, and maintaining a healthy weight. If you're currently taking an anticholinergic bladder medication and you've noticed cognitive changes, don't ignore them. This is valuable information your doctor needs to know, and there are alternative options available. Number 6 brings us to statins, specifically simvastatin and atorvastatin. Now we're entering controversial territory. Statins are among the most prescribed medications worldwide, used by millions to lower cholesterol and reduce heart disease risk. Simvastatin, sold as Zocor, and atorvastatin, sold as Lipitor, are two of the most common. The relationship between statins and cognitive function is complex and honestly not fully understood. Some patients report memory problems while taking statins. Some studies have raised concerns. Other research has found no effect or even suggested statins might be protective. Cholesterol plays important roles in the brain. It's a major component of cell membranes and the myelin sheath that protects nerve fibers. Some statins cross into the brain more readily than others. The FDA added a safety warning about memory loss and confusion with statins in 2012, though they noted these effects appeared reversible when the medication was stopped. Studies on statins and dementia have produced mixed results. Some observational studies suggest increased cognitive decline risk. Other large studies show no effect, and some research even suggests potential protective effects. This is definitely not a recommendation to stop taking your statin without medical guidance. Heart disease is a serious concern, and for many people, the cardiovascular benefits of statins clearly outweigh potential risks. However, you should know that some statins like pravastatin and rosuvastatin cross into the brain less readily. If you're experiencing memory problems on a statin, it's worth discussing with your doctor. The relationship between statins and brain health is still being studied. Have an open conversation with your doctor about whether your statin is still medically necessary, whether switching to a different statin might be appropriate, whether your dose could be adjusted, and complementary approaches like diet and exercise. The goal is protecting both your heart and your brain. They're not mutually exclusive. Number 5 is benzodiazepines, including medications like lorazepam, diazepam, and alprazolam. Anxiety and sleep disorders drive many people to seek medical help. Often they're prescribed benzodiazepines, medications like lorazepam, which is Ativan, diazepam, which is Valium, or alprazolam, which is Xanax. These drugs enhance GABA, your brain's natural calming neurotransmitter. They can provide rapid relief from anxiety and help with sleep for short-term use. In crisis situations, they can be genuinely helpful. The problem arises with extended use. Benzodiazepines can create physical dependence, and withdrawal can be extremely difficult. Beyond that, questions have been raised about their long-term cognitive effects. Earlier studies suggested a strong link between benzodiazepine use and dementia risk. However, more recent research has questioned this connection. A 2022 study from USC found little evidence that older adults prescribed benzodiazepines face increased dementia risk when other factors are properly controlled. Concerns exist about protopathic bias, the possibility that benzodiazepines were prescribed for early anxiety or sleep problems that were actually early symptoms of developing dementia. While the dementia connection remains uncertain, what is clear is that long-term benzodiazepine use can cause cognitive dulling and mental fog. These medications lose effectiveness over time as tolerance develops, physical dependence can develop relatively quickly, withdrawal can be challenging and must be done carefully, and fall risk increases significantly in older adults. If you've been taking a benzodiazepine for more than a few weeks, talk to your doctor about very gradual tapering, which must be done slowly and carefully. Alternative medications like buspirone for anxiety, cognitive behavioral therapy for insomnia, which is proven as effective as or more effective than medications, and addressing underlying causes of anxiety or sleep problems. Never stop benzodiazepines abruptly. This can be dangerous. Any tapering must be done under close medical supervision. Number 4 is amitriptyline, sold as Elavil. It is an older antidepressant that's still prescribed today not just for depression but for chronic pain, migraines, and sleep problems. It seems versatile, addressing multiple issues with one medication. But there's a significant downside. Amitriptyline is one of the most potent anticholinergic medications still in common use. Remember that 2015 JAMA internal medicine study we discussed earlier? Amitriptyline was specifically identified as a high-risk medication. The study found that people who took higher cumulative doses of strong anticholinergic medications, like amitriptyline over 10 years, had a 54% greater risk of developing dementia. This isn't a small effect, and it isn't from a questionable study. This is solid, peer-reviewed research published in a top-tier medical journal. The American Geriatric Society Beers Criteria, a carefully compiled list of medications that are potentially inappropriate for older adults, specifically includes amitriptyline due to its strong anticholinergic effects. What makes this particularly concerning is how quietly the cognitive effects develop. People taking amitriptyline for chronic pain or sleep often notice gradual changes, a little more forgetfulness, some word-finding difficulty, mild confusion, but attribute it to getting older rather than to their medication. Better alternatives exist. For nerve pain, consider duloxetine, which is Cymbalta, gabapentin, which is Neurontin, or pregabalin, which is Lyrica. For depression, modern SSRIs like sertraline, which is Zoloft, or escitalopram, which is Lexapro, have much better safety profiles for older adults. For sleep, low-dose doxepin has milder anticholinergic effects, and melatonin or non-drug approaches may be suitable. If you're taking amitriptyline, especially long-term, schedule a conversation with your doctor about whether safer alternatives might work for you. The goal is effective symptom management without compromising your cognitive health. Number 3 is paroxetine, sold as Paxil. Paroxetine is an SSRI antidepressant commonly prescribed for depression and anxiety. SSRIs are generally considered safer than older antidepressants, which is why this entry might surprise you. Here's what sets paroxetine apart. It's the only SSRI with significant anticholinergic properties. While other SSRIs like sertraline, which is Zoloft, or escitalopram, which is Lexapro, have minimal anticholinergic effects, paroxetine is notably different. Studies have produced somewhat mixed results on paroxetine specifically, but several concerns have been raised. Paroxetine's anticholinergic properties are well documented. Some studies have shown associations with cognitive decline in older adults. It's been included on the American Geriatric Society Beers Criteria list as potentially inappropriate for older adults. The American Geriatric Society specifically flags paroxetine as a medication that should be avoided in older adults when possible, primarily due to its anticholinergic effects. There's really no compelling reason to use paroxetine when safer SSRI alternatives are available. If you're currently taking it, ask your doctor about transitioning to sertraline, which is Zoloft, escitalopram, which is Lexapro, or citalopram, which is Celexa. These alternatives are just as effective for depression and anxiety, but don't carry the same anticholinergic burden. Regardless of which medication you take, support your mental health through regular physical exercise, which is proven as effective as medication for mild to moderate depression, social connection, and meaningful relationships. Adequate sleep, stress management techniques, and good nutrition, including B vitamins. Mental health and brain health aren't separate. They're interconnected, and the choices you make should protect both. Number 2 is antipsychotic medications, including quetiapine, risperidone, and olanzapine. This category is particularly concerning because many older adults don't even realize they're taking an antipsychotic medication. Drugs like quetiapine, which is Seroquel, risperidone, which is Risperdal, and olanzapine, which is Zyprexa, were originally developed for serious psychiatric conditions like schizophrenia and bipolar disorder. They're powerful medications with significant effects on brain chemistry. Today, these drugs are frequently prescribed off-label to older adults for sleep problems, mild agitation, and behavioral symptoms in dementia. Sometimes they're used in nursing homes when residents are difficult to manage. This is deeply problematic. The research here is quite clear and concerning. Multiple studies have shown that antipsychotics accelerate cognitive decline in older adults. The FDA has a black box warning about increased mortality risk in elderly patients with dementia. Stroke risk increases significantly. Falls and sedation are major concerns. These medications work by suppressing dopamine, a neurotransmitter that's not just important for mood, but also for executive function, motivation, and memory processing. When dopamine levels drop dramatically, thinking becomes slower and less efficient. Family members often describe their loved ones as seeming different, less engaged, emotionally flat, or mentally absent. It's heartbreaking, and in many cases, it's preventable. If you or a loved one is taking an antipsychotic medication, ask direct questions. Why was this prescribed? Is it truly medically necessary? What non-drug alternatives were considered? Can we try reducing the dose or stopping it? Behavioral symptoms can often be managed through structured daily routines, reducing environmental overstimulation, addressing physical discomfort or pain, improve sleep hygiene, and meaningful activities and engagement. When antipsychotic medications are genuinely necessary, which is less common than current prescribing patterns suggest, use the lowest effective dose for the shortest possible time. These are powerful medications that should be reserved for serious psychiatric conditions, not used as convenient solutions for behavioral management in older adults. And now we reach number 1, anticholinergic polypharmacy, which means taking multiple anticholinergic medications at the same time. You might have expected a single specific drug to top this list, but the most significant risk factor isn't any one medication. It's taking multiple anticholinergic medications at the same time. This situation, called anticholinergic polypharmacy, is surprisingly common and often goes completely unrecognized. Consider someone who takes diphenhydramine every night for sleep, oxybutynin daily for bladder control, and amitriptyline for chronic pain. Each medication alone might cause only mild cognitive effects, but together they compound, and the cumulative effect on the brain can be profound. The 2015 JAMA Internal Medicine study was specifically about cumulative anticholinergic burden. The key finding: it's not just about which drug you take, but about the total dose over time. The study used a measure called total standardized daily doses. The higher your total standardized daily doses, the greater your dementia risk, and the effect appeared to persist even after people stopped taking the medications. More recent research confirms this dose-dependent relationship. A 2023 study in BMC Geriatrics found a stair-step increase in dementia risk as anticholinergic burden increased. Here's what makes this so dangerous. Most people have no idea they're even taking anticholinergic medications, let alone multiple ones. Doctors often prescribe medications one at a time for different conditions, never adding up the total anticholinergic load. A cardiologist prescribes one medication, a urologist prescribes another, a pain specialist prescribes a third. An over-the-counter sleep aid gets added. Nobody connects the dots. Meanwhile, the brain is being bombarded with anticholinergic effects from multiple directions. Neurons begin to slow down. Memory formation becomes impaired. Cognitive processing gets foggy. And it all looks like normal aging when it's actually preventable drug-induced impairment. Here's the hopeful part. Drug-induced cognitive impairment is often reversible when caught early enough. When the medication burden is reduced or eliminated, many people experience remarkable improvements. Mental clarity returns, memory function improves, energy levels increase, processing speed picks up. Your brain is resilient. It wants to heal, but you have to give it the chance by removing what's harming it. Request a comprehensive medication review. This should include every prescription medication, every over-the-counter drug, and every supplement you take regularly. Ask your doctor or pharmacist to calculate your anticholinergic burden score. There are standardized scales for this. Identify which medications are contributing and develop a plan to reduce the burden. The systematic approach involves deprescribing unnecessary medications, switching to safer alternatives where possible, reducing doses where appropriate, and spacing out medications to minimize overlap. This isn't about stopping everything immediately. That can be dangerous. It's about systematic, careful reduction under medical supervision. Online tools exist to calculate anticholinergic burden, including the Anticholinergic Cognitive Burden Scale, the Anticholinergic Drug Scale, and the clinician's interview-based impression of change. Ask your healthcare provider to use one of these tools to assess your total burden. Anticholinergic polypharmacy is preventable, it's often reversible, and it's one of the most significant modifiable risk factors for dementia in older adults, but it requires awareness, assessment, and action. Don't wait for symptoms to become severe. Don't assume your doctor is automatically tracking this. Take the initiative to have this conversation now. We've covered a lot of information today, so let me summarize the key points. The science is clear on several things. Strong anticholinergic medications increase dementia risk with long-term use. The effect is dose-dependent and cumulative. Multiple anticholinergic medications compound the risk, and some effects may be reversible when medications are stopped early enough. The science is less clear on PPIs in dementia, where studies conflict, benzodiazepines in dementia, where recent studies question the connection, and statins and cognitive function, where evidence is mixed. Here's what you should do. Make a complete list of every medication you take, including over-the-counter drugs. Schedule a medication review with your doctor or pharmacist. Ask specifically about anticholinergic burden. Discuss alternatives for any high-risk medications. Never stop medications abruptly. Always work with your healthcare provider. Monitor your cognition. Notice and report any changes. You have more control over your cognitive health than you might realize. While we can't prevent all dementia, we can certainly avoid contributing to it through preventable medication effects. Now, I want to hear from you. Drop a comment below and tell me, are you taking any of these medication categories? Have you noticed cognitive changes since starting a new medication? Will you schedule a medication review with your doctor? Your experience matters and could help someone else recognize an important pattern. If you found this information valuable, please share it with someone you care about. Subscribe to this channel for more evidence-based health guidance that empowers you to make informed decisions about your health. Remember, I'm Dr. Robert Harrison, and my mission is helping you maintain sharp thinking, vibrant health, and independence for all the years ahead. Stay informed, stay proactive.